Hello, it's a pleasure to be here speaking with you. I regret I could not be there in person, but very happy to be speaking with you virtually. My name is Dariush Mozaffarian. I direct the Food is Medicine Institute at Tufts University in Boston. I'm a cardiologist with a background in public health, and I'm really excited to talk to you today about what is happening in the United States and in some cases, actually in countries around the world, to integrate food-based interventions as a therapy into medicine, a movement that we're calling Food is Medicine. I'm going to share my slides now. As I noted, I lead a new institute at the university, which is really focused on this question of how do we start to use food as medicine integrated into healthcare. So I'm often asked as a physician, why do I care as a cardiologist? Why do I care so much about nutrition? And my answer is, well, how come every cardiologist, how come every physician is not putting at the top of their list nutrition? This is because it's the top cause of death around the world. This is an analysis from the United States, but it looks very similar in almost every nation in the world. This is looking at the number of deaths in a given year in the United States, and the different causes of death from cancers to cardiovascular disease and so on are different colors. And you can see the numbers of deaths along the bottom in the hundreds of thousands of deaths. And at the top of the list, the top modifiable cause for mortality in the United States and indeed around the world is poor diet, exceeding the deaths from tobacco, from air pollution, from drug abuse, from almost any other risk factor you can think of. And so if we want to address health, we must address the top cause of poor health, which is the food that we eat. Now, for many decades, I fear that the approach to nutrition and health has been oversimplified. There have been very, very basic targets that were sort of developed in the 1970s, and things like let's just get enough vitamins and let's avoid saturated fat and sugar, and we're going to be healthy. Now, getting enough vitamins is fine for avoiding vitamin deficiency diseases. If you have scurvy, you need vitamin C. If you have pellagra, you need niacin. It's true. And certainly, we don't want to be eating too much butter or sugar all the time, but these oversimplified targets don't really work to address chronic diseases. The chronic diseases are much more complicated. And if we really want to address cardiovascular diseases, heart disease, stroke, heart failure, diabetes, obesity, cancers, gut health, brain health, kidney health, child development, we have to move far, far beyond these oversimplified targets and start to think about foods and the effects of foods on our health. And this is my summary of where I think the current scientific evidence is and what are the most important dietary factors to think about when thinking about healthy eating to reduce disease and to manage disease. A couple things to focus on. First, there are three categories roughly of foods. There's foods that we really need to eat a lot of, foods that are protective. We really need to focus on eating more of these. There's foods that we need to eat in moderation, and we can have once in a while, and that's okay. And there's foods that we need to minimize, and I'll get back to each of those three categories. The second take-home message, beyond the fact that there's kind of these three broad categories, is that there's almost no nutrients on this list. This is about foods, and so we really want to think about food-based priorities because we've learned that you cannot create a healthy diet from an algorithm or a chemical combination of nutrients. You really have to think about foods that are consumed, their processing, how they're consumed, and overall dietary patterns. So at the top of the list are protective foods, foods that really improve metabolic health, brain health, gut health, cardiovascular health, and more. These are foods like fruits, nuts, fish, vegetables, plant oils, whole grains, beans, and yogurt. This is a positive message for patients. This is a positive message for farmers and for industry. This is a positive message for government to say that we need to eat more of these foods and get more of these foods into the food supply. Then there are foods to eat in moderation, and most of these are minimally processed animal foods like cheese, poultry, milk, eggs, butter, and unprocessed red meats. Now, in this list, cheese and poultry and milk are probably a little bit higher on the list. They actually probably have some health benefits, and some might be surprised to see cheese higher on the list, but that's because it's a fermented food, and as a fermented food, it seems to have metabolic benefits, including for diabetes, and does not seem to have strong links to weight gain or heart disease or other chronic diseases in a negative sense. And then unprocessed red meats are a little bit worse than neutral. We probably don't want to have more than one serving per week or so on average, not because of the fats, but because the heme iron and other inflammatory compounds in red meats. Red meats eaten in too high of a levels, and particularly heme iron, are very powerful pro-oxidants and pro-inflammatory foods. And then the worst thing in the diet, the worst thing is all of the processed starches, sugars, and salt. And so I say starches, sugar, and salt because I've heard many people talk about fat, sugar, and salt, and that's a big mistake. Most fats are actually healthy and good for us, or neutral. Very few fats are actually harmful. What's really harmful in the food supply is starch, sugar, and salt. And most people don't think about starch. White bread, white rice, cereals, crackers, these highly refined grains. People don't think about the fact that starch, the molecular formula for starch, is glucose. Starch is chains of glucose. And so we really have to be avoiding starch, sugar, and salt, also processed meats and other foods that are highly processed. So what's exciting about food as medicine is food as medicine focuses especially on that top group. How do we increase healthy foods for people? This isn't about penalizing food or putting warning labels on food or taxing foods or trying to get negative things out of the food supply. We also do need to do that for certain things like soda and sodium, for example. But what this is really about is increasing the good. How do we get fruits and nuts and seeds and vegetables and beans and whole grains and fish and yogurt and plant oils to people in need? And in particular, how do we get them to patients that have lower incomes, lower education, who live in rural areas, who have access problems? How do we improve health equity by getting people good nutrition? And so what this graph shows is what we are thinking about as the food as medicine pyramid. These are the sets of interactions, of treatments for different people at different levels. At the top of the pyramid, we have the most intensive interventions, which are for the smallest set of patients who are extremely sick and have multiple chronic comorbidities. At the bottom of the pyramid, we have population level prevention programs that are really for general health. And so a really important message here is the top of the pyramid is for treatment here. A lot of people talk about nutrition for prevention, and nutrition is, of course, important for prevention. But food as medicine is literally using food as medicine. It's using food as therapy, as treatment for diabetes, for high-risk pregnancy, for cancer, for obesity, for hypertension. So it's using it as a specific prescribed therapy within healthcare rather than a broad multi-decade population level preventative therapy. The other important thing to point out is all of these programs need to have integrated nutrition and culinary education to make sure that once you get food to people, you actually they can actually know what to do with it, know how to prepare it, know how to cook it. And so we'll go through these different programs. The first three tiers, medically tailored meals, medically tailored groceries, and produce prescription programs, is mostly what I'm going to focus on. The bottom two tiers are leveraging federal nutrition programs, government nutrition programs, and population level policies. So let's talk about these programs. So what happens is these are integrated into healthcare. The doctor evaluates the patient. They identify a specific disease condition. Again, diabetes being the most common right now, being targeted, but also high-risk pregnancy, heart failure, chronic kidney disease, cancer, HIV, hypertension, obesity are all also being targeted. And then often there's also a social needs assessment, not always, but often also a social needs assessment. Does this patient have housing instability, food insecurity, low income, other transportation challenges, physical challenges, which makes it hard for them to buy and cook and prepare healthy foods. And so the right patient gets evaluated and they get prescribed, just like you would prescribe a drug, they could get prescribed medically tailored meals, medically tailored groceries, or produce combined with nutrition and culinary education. And the health insurance pays for the program. So the health insurance pays for the food. They pay for the food that is appropriately prescribed for the patient. Now, research has shown that these programs applied to the patient populations I mentioned improve food-related risks like food security, nutrition security, and diet quality. They improve health risk markers like glucose control, blood pressure, and body weight. They improve patient-centered outcomes like disease self-management and self-perceived physical health. And also, self-perceived mental health. They reduce financial strain, they reduce mental stress, they reduce feelings of depression. And also, some of these interventions, particularly medically tailored meals, also reduce healthcare utilization, lower hospitalizations, fewer emergency room visits, lower nursing home use, and total medical costs. Now, for these programs to work, there's a lot else that needs to happen. You need to have partnerships with community-based organizations or for-profit organizations that are actually the vendors of these food programs. You need to integrate screening and treatment into the electronic health record and clinical care pathways. You need to have doctors receiving medical nutrition education so they know how to identify and screen and refer these patients. You have to link these programs to other government food and nutrition programs. You have to have the payers pay for it. In the United States, we have multiple payers, Medicaid, Medicare, and private payers. In countries with nationalized insurance, it's simpler. You have to have your national insurance payer cover this. And you need to have rigorous research on this. So you need to have metrics and research to show that it's working. So let's talk about medically tailored meals, one of the examples. Medically tailored meals are for the sickest patients who are at extremely high risk of coming into the hospital, being admitted to the emergency room, being admitted to a nursing home. As physicians, we know these patients when we see them. They're very sick, they're frail, they have multiple comorbidities, multiple medications. For these patients, research has shown that if you give them fully prepared, medically tailored meals, tailored for their conditions, diabetes, kidney disease, cancer, their multiple comorbidities, you actually reduce hospital admissions and you reduce nursing home admissions significantly. Hospital admissions reduced by almost 50%, nursing home admissions reduced by 70%. And that means that even accounting for the cost of providing the meals, there's a net savings of $9,000 per year per patient. These meals are typically cooked from scratch and delivered to the patient's home. It's not every meal, it's typically 10 meals per week. So you could say lunch and dinner Monday through Friday is provided to the patient, and it's delivered once per week. The duration of the therapy varies depending on the patient's need. Some patients are on these meals for a few months, some people are on these meals for 6 months, and there are some patients who have been on these meals for longer than 1 year. Like any medical therapy, the therapy continues until the patient no longer needs it. And so medically tailored meals are the most intensive intervention, but one that for the correctly identified patient actually saves money and puts money back into the healthcare system to be used on other priorities. Now, for patients that aren't quite as sick and can shop and can cook and prepare their own food, instead of giving them fully prepared meals, they're given medically tailored groceries or produce prescriptions like fruits and vegetables. And again, this is one example of one paper that we participated in. This is a pooled analysis of almost 4,000 patients who were treated with produce prescriptions across 22 sites in 12 states. These were all interventional studies, but they were not randomized. And so these are the results before versus after the intervention in a non-randomized intervention. And the average benefit was about $43 US per month given for healthy food. And so a modest benefit given for healthy food. And what did we find? We found that on average across these 4,000 patients, fruit and vegetable intake increased by about a serving per day. Self-reported health improved by 62%. Food insecurity was reduced by 36%. And hemoglobin A1C, blood pressure, and BMI were all significantly reduced, and were reduced even more if you started out with higher levels at baseline. So this is an evidence summary of all of the studies that have now been published on these programs. There's been 21 studies published on medically tailored meals, 15 studies published on medically tailored groceries, and 25 studies published on produce prescriptions. The outcomes are shown along the left side of the column, outcomes like food insecurity, diet intake, quality of life, clinical outcomes like hemoglobin A1C, blood pressure, weight, BMI, or mortality, and healthcare utilization outcomes, and then other outcomes. The colors show what has been seen in the studies. Green means that there's been positive effects or benefits, and gray or black means that there have been null associations. None of the studies have ever showed harms, and so harms have never been seen. And then the design of the studies is indicated by the colors: randomized controlled trials in dark green, quasi-experimental studies in light green, and pre-post studies in the lightest green. And so you can see on average, there's quite a bit of evidence, including from randomized controlled trials, that these programs improve food security and improve diet intake and quality. That's pretty robustly seen. There's also pretty strong evidence that these trials improve hemoglobin A1C or glucose management, although there are some null studies. And there are some evidence, although mixed, about blood pressure and weight and BMI and mortality. Similarly, for healthcare utilization, there's more positive evidence and a lot of positive evidence for benefits on healthcare utilization, especially for medically tailored meals for the sickest patients. And so this is just a snapshot, just to give you kind of a sense of the number of studies and the evidence. Most of these studies are from the United States, but there are ongoing trials in Australia. There's an ongoing trial in the Netherlands that's just started. There's a trial in Canada that's just started. There's work going on in Africa and in Rwanda that we're aware of. And so there's starting to be some food as medicine interventions in other countries, but still most of the evidence is still from the United States. Now, I mentioned this at the beginning. What I'm really excited about as a physician is that food as medicine is one of the first innovations I've seen in healthcare that's actually centered in health equity and might improve health equity. As a cardiologist, I've seen new blood lipid lowering drugs. I've seen new procedures for myocardial infarction, new drug-eluting stents, transvascular aortic valves, coronary artery calcium scans, cardiac MRIs. I mean, we could go on and on about all of the innovations in cardiology. These have all been wonderful innovations that have saved lives. And yet, in every case, when there's a new drug or a new device or a new surgery, the people that need it the most receive it the least. There's always inequities in access. People who are poor or from marginalized racial or ethnic backgrounds or who live in rural areas have trouble accessing some of these life-saving interventions. Here, food as medicine is really exciting because it's a major innovation in healthcare that is actually directly targeted mostly to patients with social needs. It could be for anybody. If you have diabetes, you should probably get a produce prescription program, but it's especially targeted to patients with social needs and screening for and looking for patients with social needs. And so I think it's the first time I've seen that we could actually have healthcare really help move us from health disparities toward health equity, thinking about moving from food sufficiency to food security, which is about calories, to nutrition security, to truly having stability of nutritious food for disease prevention and disease management. Now, I mentioned this is happening in the United States. It's incredible, the momentum in the last 5 years. These are just a few examples. President Biden in 2022 put out a national strategy on hunger, nutrition, and health, and it included food as medicine as one of the top 5 pillars. Many states are now, 15 states in the United States are now testing food as medicine in the Medicaid program, which is the program for poor Americans. Medicare, which is the health insurance program for older Americans. About half of older Americans are insured under Medicare Advantage programs. These are also testing food as medicine. Private healthcare systems like Kaiser Permanente, Geisinger Health, and payers like Elevance and Centene and Blue Cross Blue Shield and many others are paying for food as medicine or testing food as medicine. The Veterans Affairs Hospital, which gives medical care to our military veterans, and the Indian Health Service, which gives health care to our indigenous populations, are also testing food as medicine. The USDA is testing food as medicine. The CDC, the Centers for Disease Control, is testing food as medicine. The government has declared that all health systems need to have universal screening in the electronic health record for food insecurity. And that's going to start to mean if you screen somebody and they test positive, you have to have a treatment. And so that's also an innovation. The American Academy of Pediatrics and the American College of Lifestyle Medicine have both committed to training physicians on nutrition and food as medicine. The ACGME, which is the accreditation body that accredits all residency and fellowship programs in the country, plans to institute mandatory nutrition education in all residencies and fellowship programs by 2026. The NIH has proposed, the National Institutes of Health has proposed new food as medicine centers of excellence, which would be research centers that are combining patient care research and community outreach in food as medicine. The Rockefeller Foundation and the American Heart Association have together committed $250 million to food as medicine research over the next 10 years. That's the largest commitment ever made by the American Heart Association in one area of research. So really, really exciting. And there's a lot going on in both the nonprofit space and in the private sector with the food sector getting involved and getting excited, retailers and startups saying, how can we help provide food as medicine? And I think there's also interesting intersections with new things going on in medicine, in particular the GLP-1 agonist for weight loss. These drugs are effective, but they're very expensive. Most patients can't stay on them long term. They go off of them due to side effects or cost, and they have other challenges and problems. And so I think these drugs are effective, but I think prescribing these drugs without an integrated, robust lifestyle program is unethical. I think it's unethical to put people on a drug and not also teach them how to exercise to prevent their lean muscle mass, to how to eat healthy, because most patients aren't able to stay on these drugs long term, and we have to teach them how to take control also of their lifestyle. And so I think food as medicine could be a really exciting way to be combined with GLP-1 agonists. And so I think some patients, they could be on a GLP-1 drug for initial therapy for 12 to 18 months to achieve weight loss. And then if they've successfully achieved a lifestyle program, they could come off the drug for the rest of their life and be successful. Other patients may need occasional booster periods. Every 3 or 4 years, they need a year booster period, but be able to come off the drug in between. And of course, some patients will fail a lifestyle and will need to be on the drug longer term, but that's the current status quo anyway. And so I think this is a really exciting possible future direction. Now we have many, many questions that we still need to answer. We don't have all the answers. It's early days, but I think these are really interesting times. And so we need to understand, what are the optimal foods that should be in the food basket? What's the optimal dose? How many dollars per month are needed? What's the duration? Do we need to do it for 6 months, a year, 2 years? It probably depends on the patient. What are the optimal target disease conditions and populations? How important is nutrition and culinary education? How do we deliver that? What's the role of family sharing? Usually these interventions will be for the patient, but if the patient lives in a family of 5 versus lives alone, they're going to share the food. And so how do we deal with family sharing and think about that? How do we deliver the food? Do they need to pick it up on site at the hospital? Do they need to go to the grocery store and buy it in the retail setting, or do we deliver it to home? All of that's happening. How do we think about the nonprofit versus the private sector as the vendor? We have both of those happening in the United States. Nonprofits tend to know their communities, use excellent ingredients, really care about the food they're preparing, but they also have trouble with scale. They also usually can only work in their community. And if you have a major health system that needs to scale, you need to think about the private sector. How do we incorporate this into the electronic medical record and clinical care pathways? How do we teach doctors about it? Many, many other questions that I think are here. And so at the Food as Medicine Institute, we have numerous active research projects in this area. We're doing a lot of research. We're also working with the federal government and with state governments on policy and advocacy, and also engaging with the community and with the private sector to try to move this forward. It really has been remarkable, this movement in food as medicine over the last 5 to 10 years in the United States. And I think it's time for this movement to move to other countries, to move to Europe and elsewhere. It's very rare that the US healthcare system is ahead of the rest of the world in anything. And yet here, I think for food as medicine, the US is leading the way. And I hope that in your countries, in your hospitals, in your clinics, you will also start to think about how to test and integrate food as medicine. Thank you.